My name is Kate Brown. I'm a professor of science, technology, and science and society at MIT, and I'm here with my colleague, Dwy. You want to present yourself, Dwy?
Yeah, I'm Kate's colleague at the STS department here at MIT in Science, Technology, and Society.
And this is our first lecture that we're so excited to have in our Plagues and Pandemics. This is a course in the genre of History of Now for undergraduates, and we've invited the larger public, and we've got about 170 people joining us today. So we're gonna, we had hoped to also have Sylvia Hood-Washington with us, but she has yet to sign in. So today we have one speaker we're delighted to have, and Dwy will give her introduction.
Great, I'd be delighted to, yeah. So joining us, we have Dr. Kavita Sivaramakrishnan. She's an associate professor of the social medical sciences at the Mailman School of Public Health at Columbia. She studied at St. Stephen's College, Delhi, at Trinity College, and at the University of Cambridge, and completed her PhD at the Center of Historical Studies at JNU. Kavita is a scholar focused on global public health history and South Asian history, with interests in the history of epidemics and disease politics, in particular the changing role of experts and their agenda, aging and the life course in the global South, and on histories of chronic disease and toxic risks in India. She is the author of her book, As the World Ages, The Making of a Demographic Crisis, that came out in 2018. So with that, I'll turn it over to Kate to start us off with the discussion.
We're delighted you're here today, Kavita. And my first question, or Kavita, our first question is, what are the confounding factors that make a pandemic more than a virus? And also, how are we learning that epidemics magnify existing social and economic inequalities?
I think when you think of when you think as a historian, I'm thinking that now, especially today, we're thinking about a pandemic in the midst of a pandemic. And there's a way in which I think we've all realized that disease is clearly grounded in society and its politics. And I think we are now living through a point when we realize that there's something very generalizable about a pandemic. In terms of cultural events, in terms of social experiences, in terms of its politics, there's something that's both historical, that seems to be repetitive, we reenact it, we review it pandemic after pandemic. And at the same time, there's something much more than a virus in the social terms, also in its unique sense, that every society and its context goes through a particular kind of pandemic. And in some senses, then we stop calling it a pandemic because it's not transnational anymore, but it's so much about social, cultural, and political factors that are local that people will often refer to it as an epidemic. So in a way, I think some of these categories, which I think apply for virologists and others, when you think about, what is the rate of mortality? What is the time when you can call an epidemic a pandemic? As social scientists and historians, we have a much more fluid way of trying to anchor this as looking at it as much more than the virus, and thinking of it in terms of, as you know, because you're also a historian of science, in terms of looking at it through the politics of expert knowledge. Who declares an epidemic, which has its own politics, who declares the end of it, who are and the inequalities that are there at every level when you think of epidemics, which go far beyond how the virus is clearly not on a level playing field. It's affecting everyone in very, very different ways.
Dwy, do you want to ask the next question? And we're also happy to gather questions from the audience too. So if you want to send them into the chat, we will start to collate those.
Yeah, maybe I can ask the next question, which is what we were thinking about when we were designing the course, whether the pandemic, as you mentioned, looks different from different places. So what is the pandemic when seen from the US as an opening point to think historically about other parts of the globe? And what do we share and not share in common with the rest of the world when it comes to how we think about pandemics, when we define them and how we respond to them?
I think being a historian of the 20th and 21st century, I'll kind of take a temporally somewhat limited perspective when I do this comparison, if that's okay. But I think from the US, especially, I think after the 1940s and 50s, when we've looked at infectious disease and we've looked at pandemics, it's almost as if it's always been action at a distance. The sense that could this be actually happening to us? There's a kind of unwilling recognition that you could actually have infectious diseases and pandemics occurring here. And therefore, what you have is this sense of not a pandemic of viruses that's happening within the US, but constantly this watchfulness that it's happening in other places. And that's why the discourse in the US about pandemics has so often been about preparedness, of risk, of watching other places. And on the other hand, as a historian of South Asia, I feel constantly with this pandemic as well as in past pandemics, there is a sense of a pandemics of what I would call compromise. The fact that you always feel that you're in compromised spaces, that you have compromising bodies, that you've never really been rid of diseases or infections. And as a person who works in public health, we of course know that there's this kind of triple burden of disease, that you have chronic diseases, infectious diseases, injuries, everything that kind of clusters in some societies that proliferate still. But I think the perception is definitely from South Asia that there is a continuity rather than a break. There's a sense that you're living through endemic risks rather than seeing the sudden rise of an epidemic and its sudden end. So I think America has lived much more, and today being the kind of solemn occasion of 9/11, I think it reminds us again of the sorts of fears of risks of pandemics that came up after 9/11. Which was less about biological, just pandemic threats and viruses, but much more about biological, warfare and other things that came up after 9/11 in terms of the CDC and other groups having fears of biological terrorism. So there's always been this fear of this kind of plot and risk and attack from other places, I think, especially over the last 60, 70 years in the US. But I think for other places, they've been compromised by their neighbors, and you live with these kinds of risks. I don't know if I've answered it sufficiently, but I see that very much as a difference in perspective.
Yeah, we have this general question, and this is our first session. What does a pandemic mean? And part of what you see when you look at a lot of countries, including the United States, but throughout East Europe, is that defining pandemic becomes not a scientific question, but an act of faith.
Yeah.
Do you believe in the pandemic? It's no longer, do scientists say or virologists say there's a pandemic or not? So that's our question. Does something become a pandemic when a virus spreads, or when people believe in a virus spreading? Is it possible to have one without the other?
I think it all depends on who decides and names a pandemic too, right? Part of the power of having a pandemic announced or believed in is also about being able to name and define a disease. So so the power of naming it, if you don't trust the people who are actually saying, so it's a lot about science and politics of public trust. Do you really trust the people who are telling you this is a new pandemic? Has there been a longer history? If you see in the state of Punjab just now, what you see in India is that there's so many rumors about COVID just being an imaginary disease. And there's a longer history of distrust due to polio vaccines that already exists in the same state. So there's if you've not trusted your health system, if you don't trust the political and the scientific voices that speak to you, then you have, this kind of doubt constantly around you about science itself, I think. So I think it's much, I think there are different kinds of histories and mythologies of public health that people live with. And that in some ways affects the ways in which they perceive what they're going through in the present, and this politics of distrust, I think, which is deeply now, as you point out, Kate, embedded in all of our societies at several levels.
Yeah, when did, going back to the US trend, when did it occur in the United States that we ceased to trust our experts and our scientists? That seems to be something that another one of those features of pandemic, just like pandemics happen in other places, right. They don't happen to us. That lack of belief in experts and leaders, that's something that happens in other places where experts and leaders are unreliable, but certainly not here. Is this a Trump phenomenon, or is this something that goes farther back in time?
I think certainly when we teach public health ethics in my school, one of the first classes we do is the Tuskegee study, right? So there's a sense of how do you trust, I mean, based on race and, intersections of race and other kinds of inequalities. I think there's always been sections of the population who felt so deeply exploited by or industrial working class histories in Baltimore, for instance, that my colleague David Rosner works on. The fact that, you never really trust what you're told, partly because you've often been betrayed in terms of even whether it's research studies or how you become really victims of trials and other things. So there's certainly communities who've never been able to trust because they haven't found science trustworthy, and they have found themselves on the margins of this kind of trustworthiness. Also because they continue to have so little health access, and they're bearing, as we can see today, the most unbearable burdens of every pandemic.
Yeah, I'm delighted that Sylvia Hood-Washington has managed to join us. It seems like she had the wrong link. So she was out there in the crowd, and now we've got her here on the speaker screen. And so do you mind if I introduce you, Sylvia?
Oh, feel free to. Can you hear me?
Yes, we can. We can hear you and see you, which is fantastic.
Yes, feel free.
Yeah. Dr. Sylvia Hood-Washington is an environmental epidemiologist, environmental engineer, and an environmental historian with 30 years of research experience working on the impact of industrial pollution on human health and ecosystems. She is the author of Packing Them In, an Archaeology of Environmental Racism in Chicago, and also the former editor of Environmental Justice. And we're really happy to have you join us today. Are you in Chicago or in Martha's Vineyard?
I'm actually in Martha's Vineyard waiting to celebrate my daughter's wedding next Friday, actually, a week from today.
Congratulations.
Thank you.
We already asked Kavita this question, but I'd like to ask you too about the confounding factors that make the pandemic more than a virus. How are we learning that epidemics in the United States magnify existing social and economic inequalities?
Well, this is something that I started with my dissertation, which is a PhD in history of science, technology, environment, and medicine. So I've always focused on epidemics and public health disparities. This COVID-19 is actually very unsurprising to me as an environmental epidemiologist and an environmental historian of health disparities. So what we're looking at a virus. All viruses do not become epidemics or pandemics. What are the characteristics of an epidemic? It's something that has an increased frequency among the population. The virus could already have existed, but you have an increase in the rates among the population. COVID-19 is very different and very disturbing because we had never seen it before. And so this is a virus, but as in my dissertation, in my books, I had focused on tuberculosis, which is also still a pandemic. It is a global phenomenon. It's a virus. It is a bacteria that spreads among populations. But who becomes susceptible to these particular viruses or bacteria? In our case, in the United States, and I think you say that globally, is that those whose health are already on the margins. So in the United States, Black and brown and indigenous people, those are already the communities that had epidemics of obesity and diabetes, struggling with HIV/AIDS and struggling with tuberculosis. Their bodies were already compromised. So now we introduce a new virus and there's no vaccine. And so those bodies that are already susceptible to disease and already struggling with disease at disproportionate levels become the victims, the ones who die at the highest rates, the ones who become infected at the highest rates. And so there's no confounding for me. What we have is populations who are already marginalized and already struggling with high levels of epidemics and now encountering a disease, a virus, which was globally not on the planet as we understood it in 2019. So I think that's the hideous part of what we're facing. are these bodies, and we add the elderly, who just to their natural trajectory of their health, their immune systems are not going to be as strong as somebody who is healthy. What is disturbing to me at this point is that there's not a lot of conversation about it, but now we have the children who are coming down with COVID-19 becoming infected, not the mortality part. But if you look at the statistics that are being put out there by epidemiologists and public health, it's again, Black and brown children who are having this high rate of this presentation of a form of COVID-19. Again, these are the children who have asthma, who have autoimmune disorders, who are struggling with obesity, everything that takes us to a point where our bodies cannot take any more exposure, whether it's a virus, a bacteria, or another autoimmune disorder. So I hope I answered your question.
Yeah, you certainly did. Before you joined us, Kavita said that in places like India, as opposed to the United States, people don't think of this latest novel coronavirus as anything that new, that they see it along a continuum of chronic and epidemic and infectious diseases that have been continuing all along. Is that also true among people of color in the United States? That there's a sense that we know this story already?
I would say yes and no. What we know as people of color in the United States is that we have, let me go back to environmental justice because I have done a lot of work in environmental justice. We know that our bodies, that our health has become very fragile. Even when we came here through the slavery period and conditions within the slave paradigm, we knew moving up through migration into cities that we didn't have adequate housing. We didn't have adequate food sources. So our health was already being compromised from slavery to post-slavery. But in this case, what we're struggling with is the lack of access to making our bodies healthy. And I have been listening to you about, in terms, even with this vaccine that's coming, and she mentioned the Tuskegee syphilis study, which, I used to be a research associate professor at the School of Public Health. And so Black and brown bodies have already been struggling with trying to just be healthy in the United States without the adequate care, without the adequate resources to stay healthy. That part is not new. But what is new is the rates at which we are becoming infected. No other disease has devastated us like this. No, I'm sorry, this is on a scale unheard of for everyone. So yes, we're used to health disparities, but not this level of morbidity and mortality. Not being able to literally walk out your door and interact with the environment and come down with an illness and die. So for instance, for tuberculosis, which is very fascinating because tuberculosis is a bacterial-based disease, but it again is transmitted through sneezing, singing, talking. And so that has many parallels to COVID-19. The difference between the pandemic of TB and the pandemic of COVID-19 is that if we change the housing, if we had housing which was had more oxygen, more light, we could deal with the TB within poor neighborhoods. Now, no matter how wealthy you are as a person of color, if you already have comorbidities and you walk out in Martha's Vineyard and someone's not wearing a mask, you have a high risk of dying. That is a huge paradigm shift. That is like no other epidemic that has hit our community. It is not. This is historic.
Thank you very much.
Would you like to respond to any of this, or would we like to move on to questions from the audience?
I wanted to briefly kind of nuance a little bit what I said about South Asia, which is that there is a difference in expectations between what colonial subjects expected from pandemics before 1947 and what citizens expect from their state. And I think there is I mean, so often in the media in India and across South Asia, there will be often comparisons that the plague epidemic, the third plague pandemic, and so many other things are in common with what's happening with COVID, including, the 1918 influenza pandemic. And that's not really true, because your expectations as citizens from a state that had aspirations to be a welfare state are, lie very much in pieces when you realize that some of the expectations of a very globalized middle class are being answered, but not of, especially, I would say, especially a class of informal labor, of a working class that's been completely marginalized through this pandemic. And I think it's not something new. I think as a historian, I see this happening through the 1950s and 60s. I think in many parts of Asia and Africa, there was such a rush to modernize and to catch up with the West and to industrialize. So there was constantly this sense that we could compromise some groups of people whose labor could be used and be used to be the basis of industry and the promise or the aspiration that we will all at some point have better health once we reach a certain level of industrial development. And that clearly remained an unanswered promise for many people who are also citizens. And at the same time, there's a huge mobility that was offered with neoliberalism for some who could actually make these transitions and jumps, and who clearly will also feel that COVID is actually surprising for them, because they had access to privatized healthcare. And there's a way in which they could get away from it and leave New Delhi to go to London, because they're, like Zygmunt Bauman argues, these are citizens of the world. There's a global elite that can move from place to place almost in a placeless way. And that is actually now what has changed, because there is this elite of people too, who may not be sick, but who suddenly feel that their mobility is trapped. So I think it's very interesting the ways in which it's happened. I don't think it's a leveler in any way, but I think people's expectations for some, it's just the expectation of bare life. And for many others, it's the expectation of a very globalized life and access, which has been, I think, circumscribed. So I think there's a huge disappointment in a new nation as well, in many places, I think, both in Asia and parts of Africa, where people, when they fall sick, when they feel that they should have been attended to, but they're not.
We have some really interesting questions from the audience. Maybe I think we could take a couple of those out. So Rosie Pauling asks, and I think this is really appropriate for where we are ending up with the discussion, how do pandemics affect social movements historically? And one might ask, add to that, how does it affect it globally? What kind of social movements have they opened up, and what kind of possibilities for social movements do they foreclose possibly? And this is for either of you or both.
I think in terms of social movements, at least in the United States, and you see it globally as well, the Black Lives Matter movement. And I was just talking to some colleagues and friends, is that I think the Black Lives Matter movement, some people see it within the context of violence against Black and brown bodies by police forces. But I think if I look at it in terms of even the 1918 race riots, in that same period in Chicago and across that red hot summer, you were having this mobilization and moving into industrialized sectors, but you also having policing of bodies. And I love Michel Foucault. This is like a Michel Foucault, a policing of brown and Black bodies, because the brown and Black bodies are not just perceived as violent, but they're also perceived as disease vectors. Okay, so who are the ones who are on the front lines, driving the buses and working in the packing houses? And these are the individuals who are more exposed to this disease, and whose neighborhoods have the least amount of resilient housing. And so there is a movement to break away from this over-policing, biological policing, and not just military policing, but there's a policing of Black and brown bodies, and not necessarily the support of those same Black and brown bodies because of the high morbidities and mortality rates. So there is a movement here. There's like a cry. I mean, if they leave their house, where are they going? Especially for those trapped in their urban environments and already feel trapped by over-policing. Do they have the same access to healthcare? And even within the healthcare system, are they being treated in the same way? I think one of the things I've had the privilege of doing in the last 5 or 10 years is being a clinician scholar, so that I'm actually interacting with patients who are people of color or poor people who have come down with COVID-19 and who are losing their jobs and still being afraid to get in their car and drive to the hospital, or get in their car and go get groceries. I mean, it's just an incredible psychological burden to feel that, wow, I have a high risk of coming down with this disease, but simultaneously I have a high risk of losing my life by just driving while black, walking while black. You know, it's just a massive movement. It's because it's psychologically overwhelming to have to confront this new pandemic. And at the same time, the perennial pandemic of being a person of color and being perceived as a vector of disease and a vector of violence.
Kavita, do you want to respond to that?
There's a broader question which really plays over what you're saying, Sylvia, from someone in the audience, Thana Srivatana, about yes, the broader consequences of this pandemic on the mental, psychological dimensions of people. And she asks also, how do these effects, the mental and psychological effects, affect or intersect with structural inequalities that we were talking about earlier? What is the point, and what are the ways in which these two things come together?
I don't, go ahead. I don't want to dominate the conversation, but I think about this, again, this is around the migration of African-American, Eastern European immigrants into the cities of Chicago and New York. And there's this incredible headline. It's like 500,000 Dixie darkies invade Chicago. And that was like a frontline rent. I mean, these people were considered as invaders into the body politic. And they were afraid that they were bringing diseases with them and being violent. And how much psychologically, I mean, how sustainable is that, even for one individual, but for entire communities, to carry this burden of being perceived as detrimental to the body politic, but still necessary for the larger body politic to exist. So what happens if we get rid of our bus drivers and our taxi cab drivers and everyone who has to be engaged in the wheels of moving the society forward and putting their lives on the line to do their jobs, but putting their lives on the line to actually even get out of their house to perform their function? This is, to me, an incredible psychological, spiritual, and social burden. And I think this is why we're in such disarray and such, I don't know, this hideous state of being that we're in as a country. It's overwhelming.
Kavita?
Yeah, I think when you look at I teach life course epidemiology, and I think it's very relevant at this intersection, because you realize that what people go through, the mental and psychosocial stress and trauma that you go through at a certain moment in a pandemic, if you're an older person, and especially if you experience it at critical periods, right? And everyone is making some life course transitions at this time in 2020. There are some who are actually bringing the burdens, if you're in your 30s, of a recession that they experienced in 2008, 2010, right? So they've already experienced it at one critical juncture when they were students. They experience it again, perhaps now as young parents. So there is this kind of continuum of psychosocial stress that actually compounds itself over life and manifests itself in many, many ways, biologically, as well as, unless, and at sensitive periods, there's no way in which you can reverse it. These are people, all of us will experience this at a very critical time, and this will be embedded in our bodies and minds in various ways. You can have mitigation, right? You could have ways in which maybe you get a good job, in spite of going through the stress of being unemployed for a year, and you could perhaps set it aside. But there are many, many people who will not be able to overcome this. And especially for older people, when we've been working on studies of loneliness, I think there's a huge and rapid cognitive decline that's occurring due to a lack of social interaction and due to the emotional pain, really, that takes a physiological aspect when you suffer loneliness at, over months and months. So I think you can't turn away from the fact that this is a turning point across generations, that it's not only for one generation that's vulnerable, but for many, including adolescents, including mothers who are giving birth to children on their own in hospitals, right? Or older people, So I think across the life course, we are seeing this roll out in so many significant ways. And I think we haven't even begun to map it. And we'll all have to work together to do that, I think.
I want to add one other thing in here, and I hope this isn't too much for the audience. So in terms of epidemiology, there is something that we talk about environmental genomics. And so there's something that needs to be considered as we discuss COVID-19 and any further emerging diseases, which plays into the psychology of all of this. So if we look at who is at higher risk for COVID-19, right? The people with obesity, people with diabetes, some autoimmune disorders. And we know as epidemiologists that there is a lot of genomics involved in here, genetic differentiation in populations. What is not discussed to the average public is that the transition that we made from agrarian societies into industrial societies and the introduction of environmental pollutants has transformed the DNA of those populations and have produced a certain type of lingering generational susceptibility to these epidemics that are emerging and pandemics. And there is a psychology attached to that too. And if we look at that, we're going to have to sort of face the psychology that comes with, again, this gets back to Foucault and to this body politic and people who are othered. Not only are they othered socially, but now we're othering them genetically and giving rise to populations that are going to be generationally more susceptible to disease. And if we talk about even what you mentioned, pregnant moms, I mean, we have pregnant moms who now are at high risk of COVID-19 and the transmission of that virus across the placenta. This is a very large scale issue psychologically, cognitively, but then you superimpose that on the history of populations living in certain areas that have changed their ability genetically to fight off disease. It's a lot to grab our arms around. And it will take generations, I think, to effectively help manage these populations, cope with this.
Kate, there's a question that follows really well from this. Rafael Velasquez asks, thinking about future generations, how does the current climate change crisis differentiate this pandemic from what might have come before? And we've seen how the discourse has been shifted. First, there was this talk in Delhi about how the skies have never been so clear, and now there's California, which is orange. And yeah, it's such a good question, and I wonder if you have thoughts on that.
Well, okay, conference and parties in 2015. We had the Zika virus. We know that the climate is changing the earth, changing the temperature, changing the rise of vector-borne diseases. This is not, they predicted then at COP21 that we would have a whole new wave of epidemics and pandemics with changing climate. So it is all connected. We didn't have the Zika virus either. but we saw that mosquito move across. We see the hurricanes, we see the temperature. You point out California, the temperature is rising. The temperature rising is going to give rise to different climate in which zoonotic diseases can emerge, I mean, this is not stopping. This is the beginning. This is the beginning of pandemics globally, because we've changed our ecosystem and our biosystems.
Kavita?
Yeah, I think this question is really interesting because if we think of different scales, right, we're not thinking simply of the pandemic and climate change. I think we've had lots of warnings with smaller epidemics that have been the result of very, very quick and deep ecological shifts that have caused epidemics. In India, for instance, you have the stick-based hemorrhagic fevers that have come up in forests that have been very, very quickly exploited in places like Karnataka, in the Shimoga Hills, for instance. You have what's called the Kyansul forest virus, which is coming in places like that. So the interaction really between local ecologies, nature, as well as people who are harvesting those forests for timber and a range of other things. So we've had, I think this pandemic is new in some ways, but it's very old in the sense of many of the warnings we've had at an epidemic level of this kind of intersection between ecologies that are broken and the public health implications of them. We have not wanted to heed some of that, and we see that proliferation now. But I think the message has been very clear to many people for a long time. And I think what really interests me about crisis is also, are there lessons that we take away from a crisis? As a historian, I feel we've had several pandemics and epidemics. Some we want to forget very quickly. So what's the role of memory? How do we remember them? And there are many others, and deliberately so, because it's very convenient for several classes of people, especially when you see this as a kind of network of global capitalism, to forget and want to forget and move on. And there are many crises that don't really result in any kind of reform. So, is there only going to be lip service is the big question about this pandemic, or will it actually lead to structural changes? So you could be cynical and say no, and or you could say that there would be changes in terms of how we understand the climate and actually lead to interventions that are meaningful. So I think that's really a debate out there,
Can I interject on that? So when you look at the changes in epidemics over time with modernization, whether it's West or East, what happened before was that we had changes in technology that changes the ecosystem. And so we'll have typhoid fever, we'll have cholera, we'll have increases of population, which changes the burden on our water systems. But here's the difference between COVID-19 and future pandemics, is that now we've had hundreds of years of industrialization and the changes to our atmosphere. And it's not just a matter of re-engineering, like the National Environmental Policy Act of 1970 under Nixon. That followed the 1969 burning of the Cuyahoga River, where we had polluted in that city of Cleveland. The fire caught on fire. We came in, we changed how we put effluents into the water, into the air, into the soil by our environmental protection policies that came in 1970s. This is something different. This is a momentum that has been gaining for hundreds of years in the amount of carbon put into the atmosphere. This is completely different. This is something that's why we had the Conference of Parties in 2015, where our methane production had been taking place for hundreds of years after industrialization. We're at a critical point now where it's done that much damage to the ecosystem and biosphere. It's not about re-engineering anymore. It's about preparing how to get ready for the changes in our ecosystem and our biosystem after hundreds of years of carbon production and waste into the entire planet. I mean, that is something that we need to come to grips with. That's why climate change is really critical to this discussion, because they predicted that we would have these changes in these diseases, especially vector-borne diseases, with this change in temperature globally.
Thank you. We have a question from Gita Srivastava, who's asking, who declares when a pandemic is over? Can you elaborate on the historical way this has happened, possibly not based on scientific or medical determination, but rather a geopolitical, economic, or social determination? How do you see this playing out with the present COVID pandemic? Who is empowered to decide a pandemic is over?
As an epidemiologist, you're going to look at your prevalence rates and your incidence rates, your levels of mortality and morbidity. How many people are dying? I mean, we're reporting every day, you know, how many people are dying? How many new cases? That's classic epidemiology. And so when we get to a point where we reduce the number of deaths and the number of illnesses specific to that particular disease, your pandemic ceases to be a pandemic. Now, here's the difference, which I think people should be aware of. We have flu epidemics every year. However, we're now walking into twin epidemics. We're walking into the traditional flu epidemic, and now we're walking into a COVID pandemic, one which has a vaccine, the flu epidemic, and one which has no vaccine. So to answer your question, when the number of deaths and the number of illnesses decrease, you're no longer in a pandemic. You're no longer in an epidemic.
Kavita, how has this problem, when the pandemic is over, been solved in the past?
There's several, I mean, if you look at the international sanitary, I mean, several institutions have been in charge of trying to declare the beginning and end of pandemics. Whether you actually believe that they're the people who can call a beginning and end to it is a completely moot question. But I mean, if we had to simply look at how institutions function, then of course, based on the international health regulations, it is the WHO in global pandemics who's done that. And if you take the case of recent pandemics, it's, you know, there's a specific kind of regulations as to at what point the WHO will declare it over country by country, how will it look at these rates. And there's a great amount of politics going in there as well, in terms of how quickly countries put pressure on the WHO. I mean, if you think of the end of the pandemic, I think the useful way to look at the politics is to look at the beginning of a pandemic, right? How do you start with the disclosure of a pandemic? And it's all about lies, really, when you start, because no one really wants to declare or disclose a pandemic or even a small epidemic outbreak. And the WHO has been frustrated by it for decades. It's often been neighbors spying, say, Cambodia spying on Vietnam and saying they've had a plague epidemic. Neighbors spying on China saying they've had an outbreak in Manchuria. So the WHO has generally relied on NGOs or others who can now anonymously, through this GOARN, this governance system of surveillance, other people who will often report when actually governments don't report themselves. And why would governments really report? Because clearly they're at a deficit in terms of trade, in terms of stigma, in terms of really feeling humiliated. And I think most states don't want to declare it, and most states would be very, very quick to want to undeclare it and put pressure on the WHO to say, this is the end of the pandemic and this is, you know, life back to normal again. And I think simply counting numbers and cooking up numbers is very, very useful for this, because as we know, there's a huge number of undeclared cases. There's a lot of people who will still suffer too. So the pandemic clearly will go on for many people, but I think as a political and strategic decision, it will come in very, very quickly based on how election interests, on a range of other things kind of line up, and how people want this declared or not. And we know that the WHO is a hugely politicized body based on its funding networks, and on the various people who are appointed within the WHO. So I think we'll see this happening and roll out very quickly in front of us.
Thank you. Do you have another question, Dwight? I'm just scrolling through.
Kind of related to that, Angela asks, so what happens next then? Once that declaration is made, there's all this discourse about the new normal. And what does that mean to you? And will we ever, she asked, I think we have asked, will we ever get back to quote unquote normal? I wonder about the politics of that kind of formation of that question of the new normality, given kind of disastrous effects that we've seen in the last few months. For either of you.
In terms of the new normal, I think it depends for whom, right? And who has led normal lives so far. So I think in terms of what are normal lives, I think for people who can get back to travel and a range of other things, it will happen. For those who've always been compromised by diseases, I don't think it's going to be, the recovery is going to be easy at all. So I think the new normal will certainly be something where for some time people carry the baggage of a pandemic for the time that they do. But I think for most people, especially for industry, there's a hurry to get back to business as usual. And I think I see that as the biggest flaw when you see crises like this unfold, especially when there's an opportunity, which is why I don't like to study epidemics as much, because people tend to think there's closure, right? There's a moment of drama and there's a sense of closure. While if you're looking at something that's chronic, you could actually study it across time much, much more with, thinking that it actually, there is no specific end to it. But the pretense with a pandemic or an epidemic is that it closes itself out. But we all know that there is a continuous presence of an endemic, especially I've worked on the plague. You know that there are these foci of plague, of endemic cases that always happen in some places across the world, right? Whether it's Arizona in the US or parts of India or parts of North Africa, where things will always flare up when there are these intersections that happen. But that will continue. But I think this new normal is very tough to think that people will actually learn lessons from it.
We have a question from Chami Yang asking about the role of people in science, technology, and society studies. She says that SDS scholars, our work has complicated the notion of objectivity and authority of the scientific expertise. How can we now, so we've sort of taken down some of these experts ourselves, so how can we now position ourselves vis-a-vis the imperative to restore trust in science? Is that a goal we should have in the academy?
I think there's a difference between, there's academic writing, right, which is critical of the place of experts. But I think we all realize that when it comes to policy and advocacy, we're also looking at how our knowledge translates itself into policy terms. And I think while we've been open to being skeptical about experts, I don't think science and technology studies have actually said that, we can question the fact that there's any kind of objective scientific truth. But I think what we've done as historians is never come to a point when we've said the one thing is right or wrong. But that doesn't really mean that we haven't said that science can't be validated. We have just said there are certain ways of establishing proofs, there's certain ways you can be accountable, and that knowledge changes and shifts over time. So it's a question of how you want to read. Recently in one of his talks, Eric Foner in Columbia was saying people, they're Republicans who are reading the histories I write are being read and interpreted in different ways. So you could use STS studies as a weapon to be able to say we're anti-science, but I certainly think we're not by any account. I think it's a way of, critique is a way of validating a certain kind of discipline and way of thinking, I think. And I think that's a very strong offering that we do, that STS plays, I think.
Thank you. Did you want to respond to that, Sylvia?
I can't, because I have two hats here. So I am a scientist and an engineer, and I am also historian of science, technology, environment, and medicine. Yes, there's scientific information that evolves over time, but there are some absolute truths that we're dealing with. And I think there is a need. There is a need to, by the academy and in our educational systems, to make people understand that everything is not on a spectrum, right? If I get a test that says that I'm a diabetic with an A1C of 7, all right, and I have the conditions that manifest it, that is an absolute truth. That is not subjective, period. If I go in and take a test for COVID-19 and I present with symptoms, that is an absolute truth. And we should not encourage people to think that it is not. And I think what has happened, what is to the disservice of the United States, is that we have so much information out there and people Googling things and trying to discern things without the proper training. There is value in medical training. There is value in training as an epidemiologist or biostatistician. And it is a rigorous training that gives us a level of objectivity to make public health decisions. It is not, we need to restore the confidence in certain parts of the population so that we can then act as a society to reduce the level of COVID-19 cases. There is a reason, that people should wear masks. It is not random. It is not something that somebody just decided to do overnight. And I think that the STS community can help in that discourse and reach out to the larger public. It is not, science is not random and it is not subjective, not all the time. We have discoveries, yes, it changes the level of science, but there is some basic science which has brought us to this level of health in the United States and globally.
Thank you. We're running out of time. At MIT, we always finish up 5 minutes before the hour. I want to thank you both very much, Sylvia and Kavita and Dwight, for joining me today. It's really been fantastic kickoff to this series. Next week, September 18th, same time, 2 o'clock, same link. We're going to talk about race and pandemics with Adia Benton from Northwestern University and Catherine Olivarios at Stanford University. I hope you'll come back and join us again. And thank you very much.
Just very quickly, there are dozens of questions and we're sorry we couldn't take all of them. And we'll keep a tab of these and maybe circulate it to the panelists later on. Thank you very much.
Thank you.
Thank you. Thank you for having us.
Yes.
Bye-bye, everyone.
Bye.
Bye.